According to the present data, peri-implant diseases are very common. Therefore, it is imperative for the clinician to inform patients accordingly before implant therapy, and to examine and evaluate patients who have been provided with implant-supported restorations on a regular basis. The following recommendations are made for the clinical routine. Before implant placement, when implant treatment is considered, patients should be informed of the risks of biological complications, peri-implant diseases, and the need for the preventative care. An individual risk assessment should be performed, and modifiable risk factors such as smoking should be eliminated. Treatment of periodontal disease, aiming for elimination of residual pockets with bleeding on probing, must precede implant placement. During implant placement and prosthetic reconstruction, implant position should be selected, and superstructures should be designed in a way facilitating sufficient access for regular diagnosis by probing, as well as for personal and professional oral hygiene measures. Clinicians have to be aware that implant placement at submucosal level to hide crown margins may carry a higher risk for peri-implant diseases. To facilitate personal oral hygiene, clinicians should consider having keratinized, attached and immovable tissue surrounded the transmucosal implant portion already during implant placement or during abutment connection for two-stage implant placement. The correct fit of implant components and the superstructure has to be ensured to avoid additional niches for biofilm adherence. If cemented implant restorations have been selected, the restoration margins should be located at the mucosal margin to allow meticulous removal of excess cement. After implant placement and prosthetic reconstruction. Since infection control is essential in the prevention of peri-implant diseases, patients have to be instructed on their personal oral hygiene with regular monitoring and reinforcement. Professional supportive care should be established according to the individual needs of the patients. For example, 3, 6 or 12-month recall intervals, and their compliance has to be confirmed. Particularly in patients with a history of treated aggressive periodontitis, indicating an increased susceptibility for periodontal and peri-implant diseases. Shorter recall intervals should be considered. During recall, peri-implant tissues must be regularly examined, including probing assessments with special emphasis on bleeding on probing. Peri-implant mucositis, when diagnosed, must be treated as it is the way to prevent peri-implantitis.